So hello, everyone. My name is Brianne Woolheit, and I am a current MPH student here at Harvard Chan in the Department of Social Behavioral Sciences, and I also am a maternal and child health concentrator here. So today I have the pleasure of introducing Dr. Kathleen Stratton. Dr. Stratton began her career at the National Academies of Sciences, Engineering, and Medicine in 1990 in the Institute of Medicine. She has spent most of her time with the Board on Population Health and Public Health Practice. She has staffed committees addressing vaccine safety and development, pandemic preparedness, environmental and occupational health, drug safety, and tobacco control. She was given the Institute of Medicine Cecil Research Award for sustained contributions to vaccine safety and made a staff scholar in 2005. She has most recently directed studies on accounting for socioeconomic status in Medicare payment programs and on the health effects of electronic cigarettes. She is currently involved in workshops on the intersections of infectious disease and opioid epidemics and on brain health. She received a BA in Natural Sciences from Johns Hopkins University, a PhD in Pharmacology and Toxicology from the University of Maryland at Baltimore, and completed her postdoctoral research in the Department of Neuroscience at Johns Hopkins School of Medicine. So without further ado, please join me in welcoming Dr. Kathleen Stratton.
Thank you all. Marie, it's good to see you again. It's good to be here. Let's see if I can remember how to do this. There we go. What this title should really be called is Marie McCormick. I always used to use those initials as the abbreviation in my notes for all the work that we did together, and it was a lot of M's and C's, but I never thought of it as maternal and child health. It was always Marie McCormick. And the National Academy of Sciences Population Health portfolio. I will talk a little bit about the breadth of work Marie has done with us, two very special projects that Marie and I worked on together, and I hope there to talk about some of the issues that I think are very evergreen, even though they were time limited for Marie and me. So what do all these important topics in maternal child health and population health have in common? Low birth weight, prenatal HIV screening, research design, developmental outcomes and measurement, environmental exposures. What do they all have in common? Marie. That's what they all have in common. So why did the academies, mostly the Institute of Medicine, now called the Health and Medicine Division, but other parts of the academies as well, why did we always turn to Marie for help? Well, this is why. She has depth in medicine and public health. She has strong methodologic and analytic skills. She's really good at reading group dynamics and is a consensus builder, and as we heard in the last session, crossing silos. She has a spine of steel, and we'll talk about that a little bit later. She has resolve and tenacity. She is wise. She's very empathetic, but does not suffer fools gladly. And she has, and this is one of the things I loved most because we had some tense moments, not us personally, but the things that we worked on. She has a very sly and wry sense of humor. 35 years ago, the Institute of Medicine released a report on preventing low birth weight. It was a committee of luminaries, and there was a young assistant professor from the University of Pennsylvania on that committee, and that was Marie. And that was the first work, if our internal database is correct, I believe that is the first work that Marie did for us. In 1982, I believe the rate of low birth weight was 6.8%, and now it's in the 8s. So this is an issue that is certainly evergreen, and I am not a physician or an MCH expert, and you all know more about why that is and the reasons for the statistic these days, but it began at the academies for Marie with maternal and with low birth weight. In 1999, Marie chaired, and this was mentioned a little bit earlier, all the work that Marie has done. Marie chaired a committee that released a report called Reducing the Odds. And this was also preceded by a 1991 report that Marie also chaired. So it was her second go-around on this important and controversial issue. These are sort of the big categories of topics that were in that report, of the recommendations and conclusions, which were not without their controversy. If it wasn't controversial, we probably wouldn't ask Marie to be involved. And I show this mostly to show the variety of topics in the report, showing the challenges that Marie found in steering the committee through a lot of landmines. And this is probably around the time that I met Marie for the first time. Here's where I'm going to spend a bunch of my time. It was mentioned earlier that Marie had worked on vaccine safety issues with us. So the National Academy of Sciences has a congressionally recognized and mandated role in vaccine safety, as put out in the 1986 National Childhood Vaccine Injury Act. And that program is run between HRSA and the Department of Justice. But this series was done for CDC. So CDC had a problem. This started in 2001. Andrew Wakefield put out his paper in 1998. There was the beginning of, not the beginning, it was the middle of a long history of concern about the safety of childhood vaccines. And CDC was getting a lot of pressure from mostly parents groups about what to do about vaccines and why aren't you studying this and why aren't you studying that? And CDC felt they needed help from an independent body to make sense of some of these worries that were out there. And so they contracted with us for something a little bit unusual, which is to do 3 reports a year for 3 years on individual topics of vaccine safety. To not only look at the evidence about whether the adverse event that was being observed was related, either associated or causally, but also to help CDC think about how much they should be worrying about this and what they should be doing and how should they be communicating about these risks and what research should be done. So when we thought around about what chair we were going to talk into this endeavor, we went to Marie. Inevitably, there was going to be a lot of research that wasn't clearly definitive one way or the other about whether or not these adverse events are related to the vaccine administration or not. Or there were going to be some adverse events that were very worrisome and that had been around for a long time. People have worried about whether the flu vaccine is causally related to Guillain-Barré syndrome since 1976. Probably even before that, but really starting in 1976, and here in 1991, we were still worried about it. We're still worried about it today. There was also a lot of societal concern and parental anger. And I will say that our public events, of which there were 8, were really rarely pleasant, although the work within the committee was always cordial, because that's the tone that Marie set for everyone involved in this project. Marie was pilloried by many during the course of this as the face of the Academy's voice, the Academy's face on this area. It was Marie. She still appears as a target of some anger. I think the latest blog post I saw was 2016, where Marie was pilloried. She did a beautiful and masterful job in front of the House Government Reform Committee when she was being attacked for not understanding what autism was. There was, unfortunately, improper access to National Academy's privileged material, information, which was then stolen by a member of the staff of the House Government Reform Committee and leaked and used in court proceedings. And in the state in which it was used, those confidential materials were made public on the internet for everyone to see. And the biggest target, of course, was Marie, where sentences were taken out of context over and over and over again, trying to put words and sentiments into Marie's mouth that anyone who knows her knows she would never say or mean. There were a lot of subpoenas. That was mostly my problem to deal with because they were to the academies and not to Marie. But it was just a lot of work, all because Marie and about 13 of her colleagues said 3 times that vaccines don't cause autism. And that was what we were putting up with. There were very silly and not very imaginative attempts to mock her. And yet she steered the committee with dignity and rigor. And then she went on a few years later to join the National Vaccine Advisory Committee, the federal group that advises on vaccine issue, and chair the H1N1 Vaccine Safety Working Group. Yes. So, what's evergreen about this? This is just Marie's and my personal history, which was fun. The vaccine safety concerns never go away. Could I get some water, please? And they never really should. But we still have outbreaks and pockets of unimmunized children. Sorry about this. So communicating scientific information to the public is really difficult. And I think that that's something that we learned. We all know it, we've all experienced it, but it really came home in this particular project. We tried very hard to turn the very formal, didactic expressions of strength of evidence and levels of evidence into something that would be meaningful to the public. And I have to say we probably weren't ever successful at that, but it's very, very difficult to explain. That is something that I really think needs to be done. I think since then some of the groups, not the least of which is the Guide to Clinical Preventive Services and other professional organizations that do evidence reviews, are doing better. We were stuck with a slightly a historical way of describing things. So I think that that is something that remains. It's a challenge for population health to this day. I think balancing parental rights and the public health imperative is always difficult. Of course, I'm here in the state where the 1905 Supreme Court Jacobson v. Massachusetts was involved in the question about whether smallpox vaccination could be mandated. It can. I think that we're still grappling with less than ideal vaccine efficacy and how to explain that to parents, because it's the important part of the risk-benefit, especially with the influenza vaccine and perhaps with the DTaP vaccine, not for all vaccines, many of which are incredibly effective, as we all know. I am fully immunized, so I can understand this, but parents have a hard time when they find out that the CDC puts out data that vaccines are only effective, but yet you had to give them to your child, and they're worried about the side effects. Excuse me. And I think it's also hard explaining to the public when and why conclusions about evidence changes. When there's the accumulation of new studies, new evidence, and you can say, well, we didn't really know in whatever year whether the flu vaccine causes Guillain-Barré, but a couple more studies and now we do, and they want to know whether maybe you didn't look hard enough, the first time around. What has changed? And that's a tedious and long and technical thing to explain. And I don't think that we know the answer to that. Sorry, these are just the topics that this committee dealt with. You can see autism 3 times. A lot of worry about demyelinating conditions, hepatitis B vaccine and multiple sclerosis, flu vaccine and Guillain-Barré. And we worked on these for a long time. In 2017, well, when we started, it was 2016 when we started, Marie and I think, found out that we were getting a little bit older than perhaps some of the topics, because pot was now called weed and marijuana was now called cannabis. So we had to change our vocabulary a little bit, but we did it. I will say that this report is the 8th most common download from the National Academy Press website. It has been downloaded 80,000 times. That's a lot for us. That's really a lot for us. So good job, Marie. And it keeps going up. I mean, I looked at the little chart just the other day. So as many of you know, 9 states and DC have legalized recreational cannabis use, and 29 states have medical marijuana. Over 200 million Americans have some kind of access to marijuana in some legal sense. This project was tough. Marie chaired this committee. It was really tough. It was a short time frame. There was a lot of literature, but in fact, the relevance of much of it was up in the air, because marijuana. No, cannabis as a product has changed a lot since I was in high school. Not that I would know. It's more potent. It's very, very different. So comparing the data from studies back then to now is hard. Most of the studies are observational, and federal law makes research very difficult. And people are using it for a wide range of conditions. And here I have you can just look at that if you would like. Marie, of course, there were questions, of course, about the use of cannabis by pregnant women. There was a study released in late 2017 conducted by Kaiser Permanente Northern California that said that between 2009 and 2016, use of cannabis by pregnant women went from 4.2% to 7.1%. There was another study, another JAMA study that showed lower numbers, but still seeing an increase in the use of cannabis by pregnant women. So physicians and public health practitioners really need to know what to tell women. Because you need to have evidence, you need to know what the data are. Use in teens is on the rise. The incidence of one or more use of marijuana in the last 30 days is going up, one of the many metrics in these surveys. In 1991, it was 14.7%, and in 2013, it was 23%. There's been a slight decrease the last 2 years in the past 30-day use. And what's interesting, the rate is so much higher than tobacco use, than cigarette use. So while we've done a great job at getting teens not to smoke cigarettes, the use of cannabis is certainly increasing. These are obviously important findings of great value, and I will say that I know that states around the country are using this material, repackaging it, looking at their particular list of conditions for which it can be used for medical uses, and beginning their communications and their understanding with that report. I think that the evergreen lesson here, again, is that healthcare practitioners and public health practitioners don't have the time or sometimes the skill to make sense of voluminous bodies of literature, especially if it's someone outside of their field. So they need somebody to do it. We have often provided that role at the National Academies in a variety of topics, and we certainly did it here. Again, Marie, I don't know what your experience was in trying to talk about this afterwards, but communicating that formal language that the committee used about the evidence, as when the vaccine stuff, it's really tough. It's really tough. There's a need for updating, obviously, because as more and more people use marijuana, it's legalized, there'll be more studies, there'll be different studies. So how do you decide when to update a body of literature in terms of providing advice to practitioners or to the public about what the current state of the science is? We've seen that in both vaccines, and it will happen in cannabis. And then there's 2 other small points, but there's a lot of shoddy reviews out there. There's a lot of systematic reviews using the kind of methodology that the Institute of Medicine laid out, as well as many, many others. There's really sort of a lot of shoddy reviews out there. And understanding that and going through what a true systematic review is really changed some of the committee members' lives who had never been involved in that sort of a thing and gave them a different perspective. And just the experience of working in a team and doing evidence reviews, I know, changed the professional career path, the track of at least one member of that committee. And that's something many of you have been touched by Marie, but there are other people out there who just for these 1 year, 2 year stints, she was able to change their career. So why does population health need people like Marie? She's willing to tackle the tough and complicated issues. None of them have gone away. Wisdom, rigor, and integrity never go out of style. And so on Marie, on behalf of Kata, Sarah, Mike, Alicia, Donna, Michelle, Lee, Jennifer, Rose, and me, thank you for, all you have taught us and all the time you gave to the academies and all the good work that came out of it. We're indebted to you. And I just want to see if you recognize these 3 little code words from our years together. The McCormick Spice Bottle, a dark-haired European researcher, and leopard-spotted bathrobes. She does remember all 3 of those. So with
That coaster would be worth thousands of dollars.
I have a couple of them I can put on eBay. So maybe at the reception we'll tell you what the bathrobes and the handsome European researcher is all about. So on that, thank you very much, and thank you.
Hello, everyone. So next on our agenda is Rear Admiral Dr. Wanda Barfield, who unfortunately cannot join us. We appreciate your patience through technical difficulties. But I just wanted to note that Dr. Wanda Barfield's team. Pat, do you want to come up? You can hear me. Okay. I must have done something wrong. I just wanted to make note that Dr. Wanda Barfield's team has worked extensively on preparing the presentation. We had 5 versions until the day before, and then unfortunately yesterday something came up and she couldn't join, so in lieu of her presentation, she has provided a video presentation, so we hope you will enjoy, and then we will proceed according to the agenda. So again, thank you especially to the people sitting right there as we go back and forth trying to make use of the few seats we have for our student introducers. And ready? Okay.
All is saved.
All right. Thank you all. We will start momentarily.
Good afternoon, everyone. My name is Dr. Wanda Barfield, and I direct the Division of Reproductive Health at the Centers for Disease Control and Prevention here in Atlanta. I'm sorry that I can't be with you in person today. However, I'm very pleased with the opportunity to share in the celebration that you're having for a remarkable person, Dr. Marie McCormick. So you may see in my office that I have some photos of my children and family. And Marie, I just wanted to let you know that these boys have grown up. Marie knows my sons, both Joseph and John, and probably the last time she saw them, they were quite tiny, but they're now quite large young men, with my oldest son now being 6'3", including the hair, and John is probably now taller than Marie. But they send their greetings, and I just wanted to share that with you. But I think one of the things that's very important is that Dr. McCormick has meant a lot to me, both personally and professionally, and I think many of you would agree that she has made remarkable progress for us all in the field of public health and in maternal child health. And although I just have a few minutes with you, that will not aptly describe all of the wonderful things that she's done for maternal child health, but I'm certainly going to try. So I want to forego a more formal presentation, of science and data to really talk about how Marie has been a truly remarkable, illustrious, eminent, amazing, impressive, talented, celebrated person in the area of maternal child health. And although all of these attributes describe her very well, I just want to talk about what I think are 4 fairly succinct attributes that really describe the work of Dr. McCormick over all of this time and how special she's been to all of us. So, as you know, Dr. McCormick's pedigree is very impressive. Emmanuel College, Johns Hopkins University, and the Johns Hopkins Hospital, where she did her medical training as well as her clinical training. She has done immense work in the field, and when she came to Boston in 1987, she was an associate professor of pediatrics and the director of the infant follow-up program at Boston Children's Hospital. In 1992, she then was selected to be the chair of maternal and child health at Harvard School of Public Health, and then she later held that position from that time until 2003, when the program was then combined into the Department of Social and Behavioral Sciences. And this has been a strong program with funding in maternal child health for now over 60 years. I just say that all to say that we know that Marie has been wicked smart. Now, Anton Chekhov would more keenly say, knowledge is really of no value unless you put it to practice. And put it into practice she did. So Marie has been internationally recognized for her work on the outcomes of high-risk infants, particularly preterm infants. And she's really looked at evaluating programs and these infant outcomes. She was the co-principal investigator in a demonstration program that assessed the effect of regionalized perinatal services, and that has greatly contributed to the reduction in infant mortality. I think one of her most important roles, and maybe actually one of her more challenging and maybe even somewhat dangerous role, was her work on the Committee on Immunization Safety. But that work was really important, and it was one of the things that I really respected around Dr. McCormick in terms of her personal integrity to really demonstrate the evidence. And what that evidence found from that committee was that there was really no association between immunizations and the risk of autism. And it was an important landmark work that that committee did. But again, amidst all the controversy, it was also very, I think, personally challenging. But again, a really important opportunity to show how important data and evidence is in improving the health of children. She also continued her work on the National Vaccine Advisory Committee, where she chaired work to look at the safety of the 2009 epidemic of H1N1. So it's really to say that she's been really truly a pioneer, and that she has not been your regular doctor. So she's also been committed in the influence of the field in MCH in particular, and it's just to say that Marie has been a real ma to MCH. And when I say true to MCH, she has really shown her dedication through over 30 years of work to sustain and advance the discipline of MCH through both evidence as well as science. You know, she has been so incredible in her vast understanding of the field. She understands the players, she understands the influences on the system, she understands how these issues interact so completely that there have often been times where I've reached out to try to talk with her about a very difficult challenge, and she's been very easily able to put many issues into context to help me to identify who are the leaders in the field and where's the current state of the science, so that it has helped me, particularly in one area such as teen pregnancy, to really understand where we needed to do and where we needed to go in terms of moving forward as a division and ideally as an agency. I also wanted to talk about finally the fact that Marie makes a great chowder. And I don't mean like a chowder in the sense of, you know, food, but although I think that, you know, given that she's lived in Boston for 30 years, that she probably could whip up a good chowder. But I mean, she has contributed to the rich diversity that's like a chowder in terms of the work of MCH. She has mentored and supported a diverse cadre of MCH experts, from students and the work that she's done with the biomedical sciences program through Harvard Medical School, to the training that she is doing currently with clinical fellows in the work with the Beth Israel Hospital and the Harvard epidemiology work, as well as the work that she's currently doing with many at the School of Public Health. And I would say that that legacy is spanned generations, and it's been so wonderful not only to learn from her, but to also see the generation of young scientists that she has helped to foster, who are now distributed throughout the country and internationally. And I'm really proud to say that I'm a part of that legacy. So I just want to conclude and say that Dr. McCormick's legacy has influenced our daily work at CDC. The work that we're doing on a system called Locate has been influenced by her pioneering work in MCH and perinatal regionalization. The work that we did with respect to teen pregnancy has also been greatly influenced. The work that we're doing to understand maternal mortality and the Maria system is another area where we've had an opportunity to work with Marie. Some of it directly, some of it indirectly, but she's really made great contributions in this area. In addition, she's given us an opportunity to build capacity more broadly through MCH evaluation and in the collaboration with the MCH epidemiology program, or MCH EP. The maternal child health epidemiology program consists of 14 state-based MCH epidemiologists who work vigorously to build capacity at the state and local level, to build data, to help that data in terms of making sure that we're doing work that's applied but yet based on evidence, and also to help with peer exchange opportunities. As I mentioned, we have 14 assignees who are based, and the photo that you may be looking at now are our current assignees as well as those that support them in our Atlanta-based team. So finally, every January, when it's way too cold in Boston to really be there, we have what we call our annual maternal child health evaluation program, or Harvard Practicum. And it's a practical program that's done during the winter break to evaluate MCH programs here in Atlanta. The students and their state program liaisons come each year to meet in Atlanta. They determine an opportunity to evaluate a program, and then they actually spend time in the state conducting the evaluation and providing a plan for the states. This has been a great practical experience that's been very well received by states, because as many of you may know, there are a lot of great programs in MCH, but sometimes we're limited in our capacity to evaluate these programs. And again, each January, students, the fellows, our assignees, as well as our MCH staff from states come together for this evaluation. And if you see the picture here, we can see that these were last year's participants. Also, another colleague who's from CDC, Dr. Mary Brown, who leads the Healthy Homes Initiative, has been involved in this activity with us. And actually, it was an initial activity that happened with lead, but then due to some issues with regard to cuts, it was then expanded and combined with the MCH epidemiology program, and it's really been a huge success. Also, I just wanted to add that 2 weeks ago in Portland, Dr. Marie McCormick received the prestigious Zena Stein and Mervyn Susser Award for Lifetime Achievement in Maternal Child Health Epidemiology at the 2018 MCH Epidemiology Awards Luncheon. And this award is notable for either an individual or a group of individuals who have made substantial differences in the field of maternal child health epidemiology. And we were really excited to give this particular award to Marie. And as you can see from this picture, there were many there who celebrated that achievement. So Marie, I just wanted to let you know that you have created a legacy that will continue across generations that include physicians, public health researchers, epidemiologists, scientists, and others who are working in both clinical medicine and public health. You are definitely deserving of this highest award, and we also want to congratulate you for your achievements over these years in MCH. So I just want to thank you for your contributions and all that you've done for maternal child health. And I hope that you have a wonderful day celebrating with friends and colleagues on this momentous occasion. Take care, and we'll talk again soon. Bye.
So Marie, we both know that Wanda isn't fluent in Boston dialects. In fact, she's from the California San Fernando Valley. She's a valley girl. So she's more likely to say for real. But she did want me to deliver the Stein-Susser Award to you. And with her enormous respect for everything you do.
Hi, my name is Machiko Minegishi. I'm an MPH student at TH Chan Harvard School of Public Health and also on MCH concentration. It's my pleasure and honor to present and introduce Professor Peter Shilaji. Professor Shilaji is an accomplished health service researcher, and professors studies to improve the quality of care and outcomes for vulnerable children have led to important changes in immunization delivery, child health care financing, and care of children with chronic conditions. Professor Shilaji is principal investigator or co-PI on multiple R01s and other grants. At UCLA, he leads the department's research efforts, the Special Population Program within UCLA's CTSI. Nationally, Dr. Shilaji has served on study sections at AHRQ, CDC, and NIH. He is a pediatric editor of the Bates Guide to Physical Examination and History Taking, which is one of the world's top medical textbooks, now translated into more than a dozen languages. Professor Shilaji is very much involved with the Academic Pediatric Association. He served on the APA's board of directors for 16 years and was APA president in 2008 to 9. Since 2009, he has been editor-in-chief of Academic Pediatrics, Journal of APA. Please join me welcoming Professor Shilaji.
Thank you so much, and it's really a pleasure to honor you, Marie, and to speak at this symposium. I'm a little bit unused to not giving scientific talks or talks about pediatric practice, but I tried to put together a little bit of a different talk. I knew there would be many junior individuals at this symposium because, Marie, you influence so many people. And so I think most of my talk is directed toward people who are more junior. They asked me, the planning committee asked me to discuss challenges in health services research and maternal child health research. So for the next 4 hours, I think I'll give you all the challenges in health services research. You know, I'm going to call it HSR, but substitute MCH for HSR because really the challenges are the same. This is Marie when she was younger pushing the rock up the hill. You've all seen different versions of this slide. And what I'd like to do is talk a little bit about just a few challenges in HSR or MCH research: funding, training, connecting, and disseminating. So you've all seen versions of this as well. Obviously, I'm not just going to talk about challenges. John Kennedy, I think, John F. Kennedy maybe said it as well as anybody. The Chinese use 2 brushstrokes to write the word crisis or challenge. One brushstroke stands for danger, the other for opportunity. So in a crisis, be aware of the danger, but recognize the opportunity. I feel we're in a crisis today in many, many different ways, and it's up to us to create opportunities out of this. So let me just go through a few challenges with potential opportunities, and throughout this, I'm going to sprinkle lessons from Marie. I must admit I'm a little bit jealous of most of you because you work face-to-face with Marie. Most of my interactions have been through the journal, so it's by phone or email or other interactions. So I think most of you have had even closer interactions, but I've taken a lot of lessons from Marie. So this is a slide from Bill Hay, just showing dollars for NIH. So this isn't MCHB, CDC, ARC, foundations or industry. This is just dollars from NIH that are devoted altogether, and the pediatric component of the dollars. So on the left-hand side is billions, and on the right-hand side is the percent that is pediatrics. And you can see it's been somewhat steady. It hasn't gone up. If you look at the blue, the dollars for pediatric from NIH at least has not increased. One could argue that it really should increase. Certainly the competition for dollars has increased. And so as I'm sort of facing a lot of young people in the audience, one of the challenge, obviously, is funding. So how do we meet some of the HSR or MCH funding challenges? And these are some lessons from Marie. So first, pursue an idea that's important and lasting and relevant. So for me personally, after the measles epidemic in 1988, I launched into trying to raise childhood immunization rates. And 30 years later, I'm still trying to raise childhood immunity. So obviously I've failed, but at least the issue is important, lasting, and relevant. And I think if you look at Marie's career, you will see this. Build career skills. So one of the ways to get ahead is to become the best at the skills that you are doing, whether this is analytic or study design. It takes a lot of self-reflection to figure out what you are good at. Collaborate. I'm going to talk a lot more about collaboration, obviously. Take advantage of your environment. I was in Rochester, New York for 30 years before moving to LA and UCLA 3 years ago. And the Rochester environment, this is where Bob Haggerty was a lot, Jim Perrin and others here, was this very unique environment where people collaborated a lot. We were able to create and build a community laboratory. I haven't been able to do that yet in LA. There's sort of different types of challenges, but take advantage of your own environment. Diversify your grant portfolio. Many senior people here have had grants from multiple different sources. I don't think I've really seen a graph that shows the direct relationship between the dollars that come in and the impact on children. Some small grants have had, and some non-funded studies have had major impact on children. Many of you have done these studies. But you need to diversify your portfolio. And persist. Did I say that enough times? That is maybe the one characteristic that leads to success. Training. There are many trainees here, and it's so nice to see the people who are introducing the speakers being trainees. So here's some challenges in HSR MCH training. There's few training programs. So I'm looking at it from mostly the lens of academic general pediatrics. This slide shows the number of academic general pediatric training programs, not in one state, but across the United States. There's very few, and a number of hospitalist programs across the United States. This is the number of academic general pediatric fellows that are being trained across the United States, which is unbelievably small. I actually don't know the number of hospitalists. It's more than the number of academic general pediatric fellows. There's also variability in training, which is one reason that I and a group of individuals have been trying to get very involved in evaluating and accrediting academic general pediatric training programs to try to reduce the variability in training and bring the level up. And these are the number of training programs that are actually accredited already by the APA. There are few applicants, and what I hear from you all is that there's few jobs, and that's partly true. So here's some lessons from Marie. So there's few training programs. Well, we need to capitalize on other programs in our institutions. At UCLA, we don't have a general academic pediatric fellowship program. We honestly don't need one because there are HSR, there are other type T32s, there are other programs, and we actually train a good number of general academic pediatricians just based on that. MCH could use that same concept. Marie has. Variability in training, I talked a little bit about the accreditation process, and we need to do better about sharing what works and sharing successes. Few applicants, too often we sort of focus on certain kinds of applicants. In the MD field, we focus on MD applicants, but I think PhD trainees are as important as MD trainees. We also need to nurture trainees really early, earlier than we are doing right now. And there's few academic jobs. I mentor a lot of people. One of the advice I give to some people is you need to sort of think ahead about your job and think in a flexible way about your job. And I'll talk a little bit more about this, so sorry. Okay, connecting. I want to talk about two aspects of connecting with lessons from Marie: mentoring and being mentored, and collaborating with others. So mentorship. So how many people here are proteges of Marie? Wow. Look around. That's amazing. For those of us, I think I probably spend 3 or 4 hours a day mentoring people. It is by far the most important activity that I do, by far my favorite activity. So it is so important to develop and maintain really effective mentor-protege relationships. Why do we need mentors? It helps us become better. It accelerates our academic growth. My guess is many of you would get there, but having Marie mentor you gets you there much faster. It enhances our organization or our institution. It's kind of like an acculturation. We all know the idiosyncrasies of our institution, and mentors do that. It fulfills the circle of academic life. I'm pushed by my proteges a lot, and I learn a lot from my proteges. And therefore, it provides meaning, more meaning than I get out of almost anything career-wise. So this wasn't, this was written by somebody else, but think about Marie. Mentors are guides. They lead us along the journey of our lives. We trust them because they have been there before. They embody our hopes, cast light on the way ahead. They interpret arcane signs, warn us of lurking dangers, and point out unexposed delights along the way. So think about your own mentors, and I hope they have done this for you, and I hope you do this for others. So I'm not going to go through this, but looking at Marie's CV, she's had these doctoral students, postdoctoral, scholarship oversight committees. The numbers are incredible, but what's even more incredible than the numbers is the sort of the successes and performance and passion of her proteges. So one way of connecting is mentoring, and spend a lot of time in these kinds of relationships, more time than maybe you think you should. What about collaborating with others? In preparing for this, so I've only been at UCLA 3 years, I kind of tried to draw a social network, not Facebook, but the other kind of social network from my own professional collaborations. So here's who I collaborate with, and I'm not special. Academic general pediatricians at UCLA. This is locally. Pediatric subspecialists, a lot. Internal medicine, biostatisticians, economists, health system leaders, CTSI leaders, and community organizations. You were just talking at the last panel about silos. UCLA is filled with silos. So what you need to do, people were asking, Jonathan, you were asking how you address silos. I sought out most of those collaborations, and many of them are new or created new. I'm not special, I just sought them out. And people are more willing to collaborate than you might think. You know, in my mind, the best way to address silos is head on. Collaborating externally. I'm not going to go through this because you've seen this slide many times. These are some of Marie's external collaborations, and I think a lot of her impact is through this. Why do we collaborate? None of us ever do great things, but we can all do small things with great love. And together we can do something wonderful. We've seen evidence of this throughout the day today in Marie's successes and achievements, and in the successes and achievements of all of you. So disseminating. I actually don't have a slide on disseminating, but maybe we'll get back to that in terms of the panel discussion, because we may be running low. So I didn't put this initially, but to me, this is the biggest challenge of HSR or MCH, which is impacting. And you've heard that word a lot. So I do want to spend a little bit of time talking about impacting. How do you make an impact through HSR or MCH? How do you individually and collectively make an impact? Because that's actually what really counts. It's not your CV. This is what really counts. So I think one way is to really reflect on what is your academic sweet spot. It's different for you than for me, but what is your academic sweet spot? And here's sort of my thought. This isn't brand new. What is important? What's important for you? What's important for maternal child health? What's important for children, for me, for primary care? What's really important? What are your strengths? So for me, my strengths are not, the reason I work with all those people is because I don't have the expertise that all those people have. So, but my strengths might be bringing them together and energizing a group and making the group better as a group than individually. What are your strengths? And what are you passionate about? What are you really, really passionate about? Not because somebody wants you to do something, but because you are passionate about that. Remember I said persist, persist, persist. It comes out of passion. It really comes out of passion. These three, the intersection of these three, is your academic sweet spot, which will make you smile and allow you to succeed by standing on Marie's shoulders. So go beyond research. This is a little bit of the dissemination. So even though much of what I do is research, for me, I've tried increasingly to go beyond research, because I think research can only bring you so far. So some of this is through the APA activities. Some of this is through the journal. I mean, many of you are editors. Jim Perrin started this journal. It's mostly service to the field. It goes beyond research. Impacting locally. So junior people, it's easier to impact locally than nationally. There is a lot more that you could do than you might think in terms of impacting locally. For me, it has been through fellow and faculty development and through community activities. Let me just give you one example. So I directed this in Rochester, what was called a primary care outreach program, which was an outreach program. This is similar to what Michael was talking about. It was a personalized approach to low-income individuals to try to get them into primary care or immunizations. It wasn't one size fit all. It was based on a social work model, sort of based on a British model. We demonstrated significant impact on improving immunization rates by 20 percentage points. And it improved well child visit rates and all sorts of other things. So we published some articles. That's cool. But my big accomplishment was I was able to convince all of the hospital systems and the HMOs, all of them in Rochester, New York, to co-fund the program. And so for 20 years, it's been funded. No more manuscripts or anything coming out of it, but it's been funded and is continuing to run in Rochester. And there's zero disparities in immunizations in Rochester, which is something like the 6th poorest city in the United States. So go beyond research. It's not just research. National things and national committees. Has anybody ever heard you say, well, say no, say no, say no, you'll advance better? Well, I think you need to learn to say yes. You need to go to your mentors to figure out what to say yes to. But the reason Marie's been so successful outside of Harvard is because she says yes to many things, and those things don't necessarily, add to her academic CV. It's because they do important things. So just in terms of our interactions, and I'm almost done, Marie was a founding senior editor. She has leadership and methods papers. She's our methods guru. She has run the ARC-funded annual report that somebody talked about before, and she's given a lot of advice. And maybe most importantly, I think I heard this as a constant theme here, she sets the standards really, really high, right, for the journal. And I think maybe that is her biggest accomplishments. So challenges of HSR, in my view, funding, training, connecting, disseminating, and most importantly, impacting. And so, my final words, there's challenges on the left side, but maybe one of my biggest lessons for Marie is find joy in health services and maternal child health research. Find joy in academics and what you do, and you will succeed, and you'll make this world a little bit of a better place, just like Marie has, and I thank you very much.
I'm Tianxin Ye, a student in the PhD program in epidemiology, Harvard School of Public Health. It's my great honor to introduce our moderator for the panel discussion, Dr. Stephen Gilman. Dr. Gilman is currently chief of the Social and Behavioral Sciences branch of the Division of Intramural Research Program of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. He is also adjunct professor in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health. His research focuses on the emergence and persistence of inequalities in common mental disorders over the life course. His work demonstrates the importance of childhood environment for neurodevelopment and subsequent onset and recurrence of psychiatric illness in adults. Please welcome Dr. Stephen Gilman.
Thank you very much. So let me ask Peter and Kathleen to come up to the podium and...
Because Wanda's going to answer all the questions.
Right. I'll just be one of many to say what an honor it is to be here today at this really wonderful event. One of the wonderful aspects of a symposium like today's is that those of us that know Dr. McCormick in one of her many roles get to appreciate how many other roles she has filled and what a tremendous impact she has made in all of them. So therefore, before opening up to general discussion, I would like to synthesize what we have learned in this afternoon's panel, what we have learned about Marie, and then offer a closing thought. So we know Marie as a scientist, leader, advocate, collaborator, mentor, and healer. As a scientist, one of her driving passions has been to understand why some children are born too early or too small, how to care for them if they are, and how to ensure their lifelong well-being. It's a different part of the PDF, but I'll tell you what it is. As a leader, she mounted landmark studies such as the Infant Health and Development Program. And the top one is, it is meant to be the title of the original JAMA article, IHDP. So many of us first had the opportunity to explore the study by downloading the data set. That was really easy. But we recognize, of course, that IHDP took strength and commitment of leaders like Marie to generate excitement and funding for the study, establish trust with participants, and maintain the study across decades. IHDP inspired the field because it proved that early interventions could be done and could improve lives. Marie was also called on as a leader in different circumstances, such as the largest, most important, and expensive study of child development that never happened. She helped us understand why and where to go next. As an advocate, she took on the challenge of the difficult and controversial. The top article is from Vaccines and Autism, from the commentary on that report. She explained in that commentary that dealing with the crisis of vaccines and their fake news reports linking to autism will require much more than science, but effectively communicating with families in the context of floods of information from unverifiable sources. In 2007, she reflected on what it will take to reduce prematurity. Let me read you a bit from that reflection. We were on the first Institute of Medicine panel that addressed the issues related to premature birth in a report issued in 1985, Preventing Low Birth Weight. On the one hand, much has been learned about potential risk factors and the biological pathways resulting in preterm delivery. On the other, racial and socioeconomic disparities persist, and we still cannot prevent or reduce the rates of prematurity. This report makes a specific organization recommendation to facilitate the need of research so that we will not be in the same position 20 years from now. And we're midway through that prediction. As a collaborator and a colleague, the large cloud speaks for itself and how valued she is. And these are only the first authors of the publications that she has collaborated on. Marie's passion for mentoring and teaching is evidenced by the filled seats here. She has mentored students, and their students. And the passion is what we saw as being on the receiving end of the mentorship. But underlying it, we know, is a tremendous investment of effort. The years I worked down the hall from Marie, I knew quite well when it was time to submit that training grant yet again, and how much work went into that. Those of us on the academic side don't always have a chance to directly witness the clinical contributions to patients' lives. Her clinical work has been essential to informing her scientific contributions. And as a former premature infant, myself, we are grateful for Marie's work at the individual level as well as the population level. So, Marie has a unique ability to tell it like it is. In this commentary on a study purporting to develop a new measure of neonatal risk, she reminded us that some challenges seem intractable, and solving them requires a fair degree of courage. The last sentence of this commentary says, "The authors have taken a first step on a long and arduous road of inquiry. Perhaps they will have the courage to continue." I think her words apply much more broadly than this one study. And courage is what we'll need. It's what we still need in the face of recent increases in rates of prematurity and stark disparities in them. So what Marie has established through her impacts in science, leadership, mentoring, advocacy, and clinical practice set the stage for the future of MCH. And so I think today's symposium is better titled "The Future of Maternal and Child Health, Children, Youth, and Families." And let me just leave you with one, for the trainees, let me leave you with one thought that I think Marie would tell you, and maybe she will after this, which is get to work. So with that, I want to thank the speakers today and open it up for general discussion. And I would like to ask Kathleen a question. What was the secret sauce? What is the recipe for getting a room filled with people who think they're very important to do what you want them to do and to come and to produce a good product at the end?
Well, we often say it's an art and not a science, so maybe sauce is the right word for it. It starts at the top, and that means it starts with the people who've chaired the groups of committees, and that's where Marie, came in. It really comes from somebody who knows how to cajole, who knows how to lead, who knows how to analyze, who knows how to ask the right questions, who knows how to just lead. So the answer is Marie, and there's people that the academies we go back to time and time again, to help lead our most difficult topics, and Marie was one of them, and it's because of that ability.
I think you're asking a sort of a broader question too, which is how can we accomplish more with people who are diverse and have potentially different opinions? And I actually think one of the keys to success is for the leader to ensure that it's not about the leader, that it's about the goals and the mission. If you can do that, you can, and if you have some energy and a little bit of EI, emotional intelligence, you can bring a group of very diverse people together. And let me give you one of my own examples. So I sit on this panel called MACPAC, which it's Medicaid and CHIP Cost and Access Commission. So we advise Congress and HHS on Medicaid and CHIP. And it's a very diverse group of 15 voting commissioners, conservative, liberal, and we had a major vote and discussions last year on what to do about CHIP, about reauthorizing CHIP. So I'd done some research on CHIP, so I could wear a sort of a research hat and an evidence hat. But what I really tried to do on that committee, which was completely split and heading toward potentially not recommending CHIP strongly, because the evidence for health insurance for children is not as strong as for some other things, is to talk about some principles. That is it right for children, if you take away a national program, is it right for children who grow up in Alabama to have different opportunities in terms of health insurance than children who are in New York or in Massachusetts? Is it right that children are punished in some ways because of some decisions, that whether either the decisions by parents or decisions by institutions? We converged on a set of principles that people from very different perspectives agreed on, and then ended up recommending a 5-year renewal with full funding of CHIP, and Congress ended up passing that, and for bizarre reasons, good reason, it ended up being a 10-year renewal because of weird stuff. But as some people in the audience know, but that was an example where, you know, so I was viewed as the pediatric, the CHIP person, but it wasn't about me. It really was, the focus was about children.
So I want to ask Peter a question, and while I'm doing that, I want a trainee to come up to the microphone and take advantage of this panel. So from the perspective of the trainees, just imagine I'm one. So how can I be a better mentee?
Want me to take it? There's an incredible book on mentorship if you want it. It's called On Being a Mentor. It's written, I can't remember the guy's name. He's in the military. Does anybody know the name of this author? But it's not just about on being a mentor. It's also about being a good mentee. So some things that proteges should do is be prepared. So I do ask my proteges when they come in to have an agenda. I kind of have an agenda for the year, but not for each meeting. So having an agenda is, I think, sort of really important. Find your balance between not wanting to ask for too much help, but not being too macho. You know, sort of find your right balance. Recognize the imposter syndrome that many of us, including me, have, that you feel like you don't really belong. If your mentor believes in you, then you do belong. Then you might be able to be successful. Push your mentor and give some feedback to your mentor. It's really hard because of the power stuff, but you can, you know how to use the word I could use this. I could, so give some critical feedback to the mentor, and watch your mentor and watch your other people. So role model, not just, you're not going to become a clone. I don't think Marie's created any clones, but I think you've all taken aspects of what she is, as well as some of your other mentors and advisors, and tried to roll that into who you are. So maybe the common theme is to be a real active protege and not to be a passive protege. And maybe maybe my final thought is try to live up to your mentor's expectations, because I bet the expectations with good mentors are really, really, really high, and that will serve you well during those low times. And in academics, there's many of those. So try to live up to your mentor's expectations. If they didn't have high expectations, they wouldn't be your mentor.
I have 3 slightly more practical pieces of advice. Just as in response to the last question, Peter said that a leader knows that it's not about you. To the mentees, the feedback, and sometimes strong feedback, is not personal. It's really not personal. It's about developing you. I would say to be brave and overcome your fears. And to know that there are a lot of paths to where you're going to end up, and that none of them are wrong, and many of them will get you there.
What is that? That means we're done? Oh, okay. Well, I want. I'm told we're turning over to the next the next section, so I want to thank our speakers and thank you all for participating.
Well, it is my distinct pleasure and honor to introduce our next speaker, Dr. Marie McCormick, the person of the hour and of the day. We've heard a lot about Dr. McCormick this afternoon, about her pedigree academically, her accomplishments. her so much about her career and contributions to maternal-child health. And so I won't rehash those. What I'd like to do instead as a means of introduction is just to speak very briefly about Marie as a mentor. In preparation for this day, Dr. Pursley actually asked all of us in the faculty if we would be so kind as to email him some thoughts about Marie as a mentor, and perhaps if we could sort of think about one word to describe her mentorship, what would that be? And it's taken me some time to think about it, and it wasn't that I was just busy on service, Dwayne. I wasn't ignoring your email. But I wanted to be reflective and thoughtful, and I have to say the word I would use would be humility. And three things kind of come to mind that I'll share with you again briefly, because I know we'd all like to hear from her. The first has to do with humility as a mentor. At the BI, we actually have a group of young health services researchers who come together every month or every other week or so to talk about works in progress. We call it neonatal work in progress, or NEO-WIP. And you know, it's those of us who are in early stages of development, from trainees to early career people and beyond, some more established people, who come and talk about their work and to get feedback. And Marie is there every time, right? As a full person, think about it, a full professor coming to listen to a research assistant, a pre-doctoral, person, to a postdoctoral fellow, to an early career investigator with multiple degrees, to come and listen thoughtfully, seriously, and to give feedback on those research ideas. I mean, to me, that's humility, right? She's not above coming to engage with us around the table. The second has to do with humility in the face of evidence, and particularly with knowing what we know, having a long view. I don't think I'll ever meet anybody who has such a deep understanding of the history of maternal-child health. She always, when I talk to her about something, she always has a story, a recollection, something about when that happened, where that came from. But also knowing what we don't know and being honest about it, being humble in the face of, not being afraid to say, I don't know, maybe we should think about that, maybe we should investigate. And the third, perhaps most importantly, is to be humble in the face of always remembering for whom we do this research, for whom we do this work, both in research and in practice as a pediatrician. We do it on behalf of children and their mothers and their families. And to me, that's the most humbling of all, right? It's not about us, it's not about the leader, it's not about the mentor. It's about those people for whom we're working. And so, Marie, I thank you for instilling me with those values as I move forward. I personally could go on and on about how my career would not be what it is right now without your encouragement over these past 10 years. So I thank you, and on behalf of all of us, I would like to welcome you to give us some thoughts.
Well, you've heard about all these wonderful things, and you've seen all these lists of activities and so forth. And so I'm going to start a little bit about how I got started. And I tell my students, just like no research is ever the way it's described in the paper, no career is ever the way it's described in the CV. Okay, there are a lot of ins and outs. And so when I first applied to medical school, I said I wanted to do research to prevent cerebral palsy and mental retardation, now intellectual disability. This goal was in response to the children that I had cared for as a nurse's aide in a local hospital, and their condition made a very strong impression on me. In other words, I didn't want to see it again. My first experience in the wet lab, while interesting, convinced me that was not where I wanted to be. Through a variety of circumstances, I was introduced to health services research, and I think Peter has made a case that the overlap between MCH and health services research is very large. I will tell you that one of the considerations was that they were giving the biggest summer student stipends from that department. It was not a well-established area of inquiry in medicine. There were only, after all, 2 to 3 academic departments in the country, but I liked the breadth and methods of research and found that I had some talent for it. And in particular, I was drawn to program evaluation. I would have to say that that research focus was not a particularly respected one. As my medical school roommate said, she didn't know what I was doing. I will say 10 years later, she said she wished she'd done it. But I enjoyed it. And as I tell my students, you really have to like research because it's not an easy way to make a living. There are really, as far as I'm concerned, only really 3 clean moments of reward in research. The first we've heard a little bit about, which is the identification of an important problem. But more importantly, you can see how to solve it, that it's actually feasible for you to do the research. The second is when the first data come in, and for me it was answers to my questionnaires and surveys. I will have to say often those responses were quite unanticipated and actually reinforced the complexity of the human experience. And finally, when you see your first results. I used to say your printouts, but of course that's outdated. And then you know a bit more than the rest of the world, and you are contributing to the world's sum of knowledge. The rest, quite frankly, can be a slog through grant applications, pilot studies, IRBs, and responding to the journal editors. So I was fortunate that I found an area of research that I enjoyed. I was also fortunate in having mentors along the way and colleagues, which have been described, who collaborated with me, and finding the resources to do the work that I wanted to do. By chance, as was mentioned a couple of times, the first program evaluation I worked on was examining the effect of a national demonstration program of perinatal regionalization. A major question was whether if you increased the survival of high-risk neonates, were you also increasing morbidity? The answer was no. But it had focused me because, in fact, at the time I was sitting on the largest data set on low birth weight infants, some 10,000 of them. As Dwayne has described, my work has continued to focus on the outcomes of pregnancy, and in particular, understanding the outcomes of very premature infants and ways to improve their outcomes. It seems a somewhat circular route, but I did, in fact, fulfill my medical school application goals because the significant problems in premature infants include cerebral palsy and intellectual disability. From very early on, I also knew I wanted to be in academia. While I was not interested in a fast-track career, I also did not plan to be an assistant professor for life. However, today's event and the kind of outpouring that has occurred was never even on my bucket list. I'm incredibly honored by those of you who came here, both speakers and attendees, and frankly, I'm a bit overwhelmed. I keep wanting to look over my shoulder to find out who these people are really talking about. After all, I was just doing what I enjoyed. So the first lessons learned personally included finding an activity or field that provides you gratification regardless of its prestige. The prestige may change. While days like today are wonderful, you may need a greater ability of delayed gratification than I had if that's your goal. The second is a little more less high-powered. Be careful in what you write in your grad school application. But we are not here just for me. We're here for MCH. Back in those days, if you had asked me about the need for MCH, especially in schools of public health, I probably would have been neutral to somewhat negative. I was a pediatrician, after all, and naively assumed that everyone understood the primacy of children and their families. I also thought everyone understood the value of immunizations, but that's another story about naivete. But experience has proven that assumption incorrect. I will give but one example. Until the most recent edition, Maxie Rosenau, the so-called textbook of public health, had no chapter on MCH, despite having whole chapters on the epidemiology of various cancers. I would like to think the current chapter, no matter how brief, and it is brief, was the result of my badgering the current editor, Bob Wallace, about the gap. Why this apparent neglect? In considering the gap in research on issues of children versus those of adults and even older adults in the United States, my colleagues referred to demography, disease, and development. The first, demography, refers to the proportion of the population that MCH deals with. For example, there are 4 million births a year in this country, and roughly 80 million women of childbearing age range. Thus, at any given year, only 5% of women are pregnant. Children and youth represent less than a third of the U.S. population. So MCH deals with a relatively small fraction of the health problems that are seen in the United States. And this is complicated further by disease, which has meant the prevalence and distribution of health problems in the MCH population. Of the 4 million births we've seen, up to 10% may be born prematurely, but only 1% of those births really require the full-blown neonatal intensive care that Dwayne and his colleagues provide. About 2% will be born with major malformations, and by the way, they overlap. Congenital heart disease is the largest contributor, but the rest are comprised of a large number of increasingly rare and unfamiliar conditions. I suspect you're all familiar with maple syrup urine disease and the gangliosidosis. Among children, less than 10% will be hospitalized in any year, and 15% will be classified as having special health care need, which is the new terminology and expanded terminology for chronic illness. Although of significance, there are only 700 maternal deaths a year. The good news that these figures suggest is that most children are healthy and most pregnancies go well. However, the low fraction in the MCH population, combined with a multitude of infrequent health problems, makes it difficult to conduct studies about both the conditions themselves and the groups most vulnerable to these health issues. And finally, development indicates that the issues affecting families and their children are a moving target. We've heard about the early adverse health events and environmental experiences may be expressed in a variety of outcomes much farther downstream. For example, we've already heard some discussion about the variations in fetal and infant growth may be risk factors for adult onset cardiovascular disease and metabolic disease far in the future. Further, changes in environment, including the policy and economic environment, may alter these trajectories both for good and for evil. In other words, the arc of the effects of childhood experiences is long. Good experiences may have great payoff, and adverse experiences may lead to a cascade of future problems. Hence the focus in maternal and child health on prevention. There's a little hooker about this prevention thing. It is largely health and education who invest in the prevention. It is welfare and the prison system that reap the rewards. So you don't get a lot of reward for doing this kind of stuff. Finally, funding for understanding and altering childhood experience is limited and spread over a range of federal, state, and local administrations, as we've already heard. The Maternal and Child Health Bureau has been a steady supporter of both education and research in MCH, but it represents exactly 0.6% of social welfare funding on child health. Peter has talked about the dollars going to the National Institutes of Child Health. That represents 11% of NIH funding. Concerns about child health are spread over welfare, the Departments of Agriculture and Education, and Financing Administration. Tracking the use of these services and understanding their effects across these sectors is not simple, either for researchers, and God knows, not for the families. I will also have to say that MCHB may have contributed a bit to some of the diminished stature of MCH in schools of public health. While the training grants like ours, now in its 63rd year, have been critical to sustaining the education of MCH professionals, the constraints imposed by these training grants in the past created problems for departments of MCH in fitting into and belonging to a changing academic atmosphere. The training grants were initiated in the post-World War II era and informed, I think, by my predecessor, Dr. Martha May Elliott. She had had major responsibilities at the Bureau for direct delivery service during the Depression and war. And thus, the focus of the grants was in replenishing the MCH public health workforce, largely for Title V agencies, okay, not for every child health service. And she did this by insisting that there would be resources for professionals to get an MPH degree and providing technical assistance and continuing education to those in the field. I will simply say that the structure of the training grants did not change for over 20 years. This is a period in which schools of public health underwent major changes, from being largely focused on master's degrees to expanding the degree programs to doctorates and their inherent need for research. In addition, the funding for the major schools of public health became much more dependent on the research being brought in by the faculty. When I took over the grant in the early 90s, I was still required to have a physician, a nurse, a social worker, and a nutritionist on my faculty, not for educational reasons, but because that was the staffing of an MCH public health clinic. Such clinics had long vanished from the Massachusetts scene, with their responsibilities assumed by more full-service entities like neighborhood health centers. The narrow focus on Title V agencies not only limited awareness of the expansion of services in these other entities, particularly in the Northeast, where we've not had a terrifically strong county government providing services, but also they sort of missed some of the professionals who were emerging, who were coming out of the hospitals, doing research and service in the community, and these were, in part, the health services researchers that we've talked about. When deans looked at these departments, they saw our faculty engaged in a variety of activities in the community, but not generating much new knowledge. I will also have to say that the dollars per year had not changed very much, so that increasingly the training grants were paying less for the MCH activities, but the programs were not contributing to the bottom line. Moreover, there was no money for doctoral students, even to replenish MCH faculty. And it also meant that developing the evidence base for MCH interventions lagged, as this was not seen as part of the mission. Much has changed since then, particularly under the leadership of Dr. Liu and his colleague, Laura Kavanaugh, ably supported by our project officer, Michelle Tissue, of whom I can only speak of the highest terms. They have been fabulous. The primary commitment of the grantees to professional education at both the master's and the doctoral levels, and the importance of generating new knowledge to move MCH forward, have been recognized in our new titles, Centers of Excellence. While support of Title V agencies is still a priority, the training programs are now actively engaged in collaboration to develop rigorous academic experiences that will both enhance the education of our students and provide the kind of assistance that the programs need. And Wanda described this in terms of this evaluation practicum, but this was really an attempt not only to provide services to the Title V agencies, but also to make sure that the students were getting a rigorous academic introduction to this. The program begins with a week course that is an intensive didactic instruction and program evaluation, and then the students go out to the field, to the states, and design a program evaluation for the state. And as Wanda indicated, it was supported by the Division of Reproductive Health and CDC. Other programs are also developing innovative strategies. One of these is a pipeline project to try to engage more underrepresented minorities in maternal and child health, and we're also beginning to link these programs, so that last year our students developed a program evaluation, and in the summer the pipeline students finished the evaluation. And in addition, MCHB has also fostering the development of MCH programs in schools of public health. Thus, I think we are entering an era with a reinvigorated cadre of academicians and professionals that will contribute to new and exciting programs addressing the needs of children and families. The alignment of concerns and goals with the Bureau and the training program bodes well for the coming years in, once again, asserting the importance of issues and identifying interventions in order to shift the trajectories of vulnerable families towards healthier futures. I would simply indicate that, besides this room, one measure of the new vigor is the large number of students in our MCH concentration, which averages 40 to 50 per year. Again, I would like to thank all who contributed to this day. It has been a wonderful celebration, and I hope we all go forward and do good things for kids.
And for me, Dr. McCormick role modelled the life and work of a clinician, researcher, public health professional, demonstrating that all three strands are possible, complementary and indeed powerful when combined.
So my mentor at the time was a neonatologist. He told me I should go and talk to the guru of follow-up, Dr. Marie McCormick. And so I made an appointment to go see her, and I was really intimidated because I was like, oh, it's Marie McCormick. And she was so nice. And I was like, Dr. McCormick, I'm trying to make this big life decision. Do I go down developmental peds or do I go down neonatology? And she goes, who is it that you want to influence? And I said, neonatologist. She's like, I can tell you it's much easier to get neonatologists to listen to you if you are a neonatologist. And the rest is history.
And then, and among those of us with centers of excellence in maternal and child health, you've been a leader. You've always stepped up with a voice of wisdom and caution and insight based on years of experience to say what we as academics in MCH can do and sometimes what we can't do to support leaders in the field. And for that, I want to thank you. We will sorely miss you.
And separately, I will just say that it's been really a privilege to work near and with Dr. McCormick. As a faculty colleague, I have learned a lot from watching her interact with other faculty, from hearing what she's thought about departmental issues and the curriculum, and watching her interact with students and head up a major program. And I want to express my deep gratitude to her for all of the work that she has done. Some has been better recognized and some perhaps less well recognized, but sometimes the quiet work is the most important. So thank you.
You and I discussed, and I don't know if you remember, you and I discussed not only the choices academically, the personal choices that we as women in medicine had many different discussions about the personal aspects of the choices we've made as physicians and as academicians. You shared that with me early on when I was so green and junior that it really helped my thinking about my own path.
Appreciation for the dedication you offer to the learning experience of our students, with deep appreciation for your sense of vision, and with delight for your ability to conduct wonderful meetings. Thank you.
I wish I could be there in person to celebrate with you. I remember the first time I became acquainted with your work. You gave grand rounds at Boston Children's Hospital when I was a resident. David Nathan, the chair of the department, announced that he had just recruited a terrific new faculty member, and then you went on to give a really wonderful grand rounds. Those of us who are interested in the intersection of pediatrics and public health research were really excited to have a wonderful new role model. I appreciate how supportive you've been of me and of my work over the years, and how much you've done for the fields of maternal and child health and quality of care. Thank you for all the wise advice and thoughtful encouragement you've provided throughout my career. I wish you the best.
My name's Stephen Buca. I joined Marie's Department of MCH in 1995 and was there for 10 years before coming to Brown to form a Department of Epidemiology. I see, Marie, that we've been cited over 1,000 times. We co-taught together, we co-directed the MCH training program and oversaw a number of doctoral theses. I'm particularly indebted to 2 lessons that I learned from you and brought with me to Brown regarding being a chair. The first is to keep faculty meetings very infrequent and brief, and we thank you for that. More importantly is to keep faculty mentoring sessions very frequent and long and unrushed. I came to realize that your approach to mentoring is far from the norm, and thank you for your generous guidance and sharing of your time. You gave clear guidance and recommendations for areas of attention and a pathway to academic success that benefited me and our faculty here at Brown. We have an excellent record of retention and promotion and now have 12 tenured faculty members, which I attribute entirely to the model which I learned from you.
A heartfelt thank you. As the founding senior faculty advisor for STRIPED, the Strategic Training Initiative for the Prevention of Eating Disorders, a public health incubator, your guidance has been invaluable. From the beginning, your inimitable combination of compassion, drive, values, and unfailing pragmatism were so important in helping us set the course and shaped this training program to be like nothing done before. And we could not have done it without you and without the support of the director of the longest running and one of the most successful MCHB training programs this country has ever seen. Thank you.
And as you remember, I graduated from HSPH 6 years ago. And I'd like to take the moment to express my gratitude towards you for your mentorship and support during my program at HSPH. And, you know, I'm so grateful to have worked on 2 research projects with you. And I think that had such a great impact on where I am today. I'm currently entering my 4th year PhD at UCLA. I'm studying health policy management, and I'm happy to announce that just last week I passed my oral.
Kelsey Holt here, excited to congratulate Dr. McCormick on a career of amazing, inspiring accomplishments. Thank you, Dr. McCormick, for all of your support of me from day 1 of the doctoral program until now. I know you'll be greatly missed within the MCH concentration at Harvard. You were always such an amazing example to us of important research and translation of research into real policy change and real improvements in people's lives. And we so appreciated your support of all of us doing the full range of different projects on different types of reproductive health issues. So thank you so much for everything. I wouldn't be where I am today here at University of California, San Francisco, without you.
Marie has been a giant in our field for as long as I can remember. Her many contributions to advancing science, practice, and policy in MCH are truly immeasurable. And whether we're talking about her research on prematurity, or perinatal regionalization, or perinatal transmission of HIV, or immunization safety, and on, her work has improved care and changed lives for so many children and families in our country and around the world. I had the honor of serving alongside her on the Institute of Medicine Committee on Understanding Prematurity, and she was such a great role model for me on what scientific integrity and intellectual leadership should look like, that those of us who follow in her footsteps should really aspire to.
One of my favorite memories of Dr. McCormick was when she informally advised me on whether or not a doctorate of science made sense for me. And I remember setting an appointment with her and going into her office, and she was very busy because she always has a lot of projects going on, and she was facing her computer, and I sat quietly until she was ready to talk to me. And then she spun around in her chair and she said, "Now, why do you want to get a PhD?" And I remember spewing out this answer that hopefully made some sense, because I'm not sure anyone else had asked me that in this investigatory process that I was in. And at the end, she looked at me very solemnly, said, "All right, that makes sense." And then we talked about sort of how to move forward. But the reason why I wanted to share this story is because I think that Dr. McCormick always has been a pragmatic voice around science, and really did want to make sure that there was some good to come of the scholarship I was proposing to do. And that's certainly the role that she's always played, at least for me, in my scholarship, is making sure that ask the question of whether or not this is going to make sense and make a difference in the world. And that's certainly something that she also provides an example for in her own work. So on this really fantastic celebration of her work, thank you, Dr. McCormick, for being that pragmatist always, as well as an exceptional scientist. I know that I hope that I take a little bit of that with me and I'm on my career trajectory.
I would say is that Marie is the kind of person that creates opportunities, and she's so smart, and she does an amazing work just on her own, the research that she's done over the years, the vision that she's had in the field of maternal and child health. But she also creates opportunities for people, and that's what she did for me. I don't know, because I never asked, what Marie's thoughts on feminism are, how she thought of herself as being really a very early leader of a department here at the school, a major researcher in the field nationally, and a woman. she definitely broke ground. She definitely was a role model for me and for a lot of people in this field and also in other fields of public health. I don't know that that was her, sort of explicit intention. I'm not sure that actually matters because she did what she did at a time that was not very welcoming of women.
I believe that Marie has been, in many ways, one of the consciences of the department. That she really looks at the big picture. She has made sure that all of the constituencies that are involved have a voice. And she tries to make sure we walk the walk in terms of really what needs to be done in terms of academics and in terms of administration. And I really appreciate that.
Do you think she puts the excellence in the center of excellence?
She is the excellence in the center of excellence. And I'm sure things will go on, but really that is, without her, the center would just not be what it is.
I would say, hey, superstar. Thank you so much for all you've done.
I think we made it. Thank you very much. I'd like to thank two people just now. First, Cersei for putting this wonderful video together and also supporting the whole day very much. Also Jeannie for example, coaching the students. So they did tremendous work, so this program is possible. One last thing. I will not say many words, but there was a committee, committee, 4 members, we had meetings. And it was a very diverse committee, disagreeing and different, national origins, you name it. And each comes from other perspectives. So one says Americans get plaques for these events, so we thought there was a plaque, why another one? Or we had one member saying it's got to be consumable because if they move, they want to get, can be able. This is not. And the third is going to be small, but it has to look very expensive. That was the third voice. And, so essentially, the chair of that committee had to decide because we couldn't agree. There was no good management, I can tell you that. So essentially, it was a sort of decision that will be neither of that old. It's just a typical, I would say, European version. That kind. It's something. What can I say? It's practical, but yet design. It goes together, and where I come from is from Finland. Thank you very much. That's it. You can probably pack it. I'll tell you what it is. This is the cliffhanger. Take it home. We have the reception now, so I don't know where it is actually. Is it should be Kresge? So do come with us. I hope that many will join us to just chit chat and talk to Marie and to see what's in the box. Exactly. Thank you very much for being here. Thank you very much.